Welcome to AETCM, the emergency medicine channel. Today I'm going to present a case, ophthalmology case. So I'm going to present a case of a 68-year-old female who is a resident of Thrissur, who came to the emergency medicine department with a complaint of loss of vision in the left eye since 2 days. The patient presented to ER, who was apparently alright 2 days back, when she noticed a sudden onset, painless loss of vision in the left eye. The loss of vision was noticed on waking up, trying to look in the mirror. Also had a difficulty reading letters on the newspaper, so tried closing alternatively her eyes when she noticed that the back shadow was persistent only in the left eye. It was non-progressive, and hence she came for the further management to our hospital. There was no history of redness, watering, flashes, floaters, any history of trauma or headache and vomiting. Past ocular history only includes use of glasses, that was for distance as well as near, for around 11 years. No other ocular intervention has been done. She has a history of systemic hypertension on tablet Silcar. Personal and family history not relevant. General physical examination was within normal limit. Systemic examination, all the systems were within normal limit. So local examination, head posture was normal, no facial asymmetry was seen, ocular alignment seen through Hirschberg test, HB test, was orthotropic. Extraocular movements in both the eyes were full and painless in all the gazes, unilateral and binocular. Now we start with the ocular examination. First we will be describing the right eye. Visual acuity was 6/36, with pinhole improvement was 6/12 parts. Subjective refraction of -2 sphere, which gave an improvement of only 6/12. There was a +3 at for near, the improvement was only N10. For the left eye, the vision was 1/16, not improving with pinhole. Subjective refraction did not give any significant change, that is why plano. And for the near, +3 with no improvement, less than N/36. So this is a slit lamp diffuse image of the patient. If you can see, there is a slight haze that can be seen in both the eyes. That is because of the cataract. Okay. Coming to the anterior segment examination, right eye, eyelids, upper eyelid covering 2 mm of the superior cornea, lower eyelid touching the limbus, which is a normal finding. Eyelashes, normal color direction, no matting of eyelashes. Conjunctiva, no congestion, discharge, chemosis, only some melanotic changes, which is age related changes, could be seen. Cornea, cornea was normal size, luster, transparency, epithelium was intact, stroma was normal, endothelium did not show any gutted. Anterior chamber, the von Herring's grade was grade 3, that means the chamber was open and it was quiet, there was no AC activity seen. Iris, normal color and pattern, no neovascularization of the iris was seen. Pupil, right eye 2 mm, direct and consensual reflex were normal, no RAPD. So this is a diagram that we have made. If you can see, this is the grade 1 NS, grade 2 NS, this is the iris, cornea clear, nothing not significant, no anterior segment findings were significant. Then the lens, right eye, there was grade 2 NS with no pigments on ACL, anterior vitreous was clear, intraocular pressure measured with the help of non-contact tonometer showed 16 millimeter of mercury, gonio showed open angles. So yeah, going to the other eye, that is the left eye. Everything was within normal limits, as I already described, the eyelids, the eyelashes, the conjunctiva, except for the finding that you can see in the pupil, it had grade 1 RAPD. Okay? RAPD is relative afferent pupillary defect with 2 mm pupil. A lens had grade 2 NS, but not it was not significant enough to justify 1/60 vision. Anterior vitreous was clear. IOP, that is intraocular pressure by non-contact tonometer, was 16 mm Hg. Gonio was open angles. Now we come to the posterior segment examination with dilated fundus examination with 90D and 20D. Right eye, if you can see, this is a fundus image of the right eye where you can see a disc, the CDR, the disc normal, color in shape, and the disc margins were well defined. The cup to disc ratio was 0.3 into 0.3 with a healthy neuroretinal rim. Macular foveal reflex is normal. Okay, and the AV ratio, that is the arterial venous ratio, was within normal limit, that is 1:3. Arteriolar narrowing is seen and AV crossing changes were seen, that implies there is some hypertensive changes. So what are the hypertensive changes that we could see is, this is the magnified image. If you can see, this is the artery, this is the vein. In the artery, if you can see, there is a bulging at the tip where the artery is being putting a force on the vein. There is slight bulging at the edge, that is known as Salu sign. Okay, there is Bonnet sign and the gun sign that is implicated here. If you can see on the screen, you can just read about the signs that can be seen. Okay. Yeah, this is the fundus diagram that I have made with only hypertensive changes. The other eye, the left eye, if you see, the media is clear, vitreous is clear, disc margins are elevated. If you look at the disc, it's not well defined. There is elevation and the blurring of the margin. There is dirty white color disc. Cup is not appreciated. Macula has a very dull foveal reflex. There are multiple extensive retinal hemorrhages that could be seen scattered all over the retina, extending till the periphery. This is the diagram of the extreme periphery going to the ora serrata. You see there are hemorrhages extensively even till the periphery. So yeah, there are pre-retinal hemorrhages, there are superficial hemorrhages, there are multiple cotton wool spots temporal to the disc. There are dilated and tortuous vessels also that could be appreciated. Yeah, look at this. These are the ghost vessels. Ghost vessels are something which means that the process has been for a long and the patient just noticed it now. Okay. Yeah, it's just a magnified image. If you can see, disc margins are elevated and blurred. If you compare it with the other image, dilated and tortuous vessels are there, multiple hemorrhages, and a typical finding that you see in cases of any vein occlusion is a tomato splash appearance, which can be seen in this image. Then there are cotton wool spots. These yellow spots are known as cotton wool spots. Okay. Yeah, this is the retinal diagram. So my provisional diagnosis is left eye central retinal vein occlusion, probably non-ischemic. Right eye grade 2 hypertensive retinopathy, both eye mature senile cataract, systemic hypertension and personality disorder. So yeah, so once we are done with the basic preliminary examination, we go for further examination, that are OCT, FFA and different modalities. In FFA, in OCT for this patient, we saw some macular edema that could be appreciated. Why is macular edema important in this? It tells us about the prognosis of the patient. If the macular edema is one of the complication of CRVO. CRVO, central retinal vein occlusion, can be of two types. One is a ischemic, non-ischemic. So non-ischemic, usually we tend to observe. We do not do anything at present. We tend to observe, look for the complications if it is developing. What can be the complication? It can go to ischemic type of CRVO. It can cause vitreous hemorrhage. It can cause macular edema, and all these have to be treated, or else the patient will lose his eyesight forever. Then there is second type that I told you is ischemic. Ischemic is a very it has a very bad prognosis because already the retina has lost most of its viable tissue. So when it's ischemic, as a defense mechanism, as a protective mechanism, the retina will try to increase the VEGF, that is vascular endothelial growth factor, which will cause proliferation of all the type of vessels, not only in the retina but even in the anterior chamber. anterior segment of the eye. So what will this lead to? This will lead to neovascular glaucoma. Okay, and that's one of the, I mean, dreaded complication in CRVO. So this is an OCT, optical coherence tomography of a macular section in the left eye that shows diffuse macular edema with PVD, that is posterior vitreous detachment, and there are few cells that could be appreciated. Okay. This is the right eye. If you look at it, it's almost like the foveal contour has been maintained, nothing like not significant changes are there. This is the FFA, that is the fundus fluorescence angiography. In left eye there is a block fluorescence. If you look at this, the images are normally like this, it's completely perfused. Okay, now if you look, there is, can you see this? There are gaps here. The vessels are not completely perfused, that means there is ischemia and there is non-perfusion at that area. The vessels are showing incomplete perfusion. Then there are no CNP areas. CNP areas are capillary non-perfusion. At the area of retina, macular retina, that will help us to tell if it is an ischemic type or a non-ischemic type. Then there is no neovascularization, that is there are no new vessels that can be seen on FFA. Normally there will be worm-like new vessels that can be seen, that usually implies neovascularization. Yeah, these are the later time images of FFA. This is the right eye, which is okay, like right eye doesn't have any changes. Yeah, thank you.